Hello and welcome to the third webinar in our series of webinars as part of Dry January or Dry Eye January, if you like. Um, Today's webinar, I'm delighted to have Professor James Walsam from Aston University, who's an eminent expert in dry eye and involved in a lot of dry eye research and a key opinion leader as far as dry eye is concerned on a global basis, not just here in the UK. So his presentation is called Why My Eyes Dry, Tired, Gritty or Watery, and we're going to talk a little bit more about that in a moment. I know there may well be some of our optical colleagues, dispensing opticians, on this evening, and this webinar will give you half a CPD point, and the C number for that point is 115044. As I say, we've now had, these are the four webinars we've been running this month largely for people who are suffering from dry eye. We've done the first two with Dermot and Diane last night, and we have James today. And I want to flag that next week on Thursday, the 29th of January, there's a QR code there if you're not already registered to listen to optometrist and co-founder of Peep Club, Nicola Alexander. And we'll be discussing various things, but particularly looking at exploring some of the modern dry eye treatments. We might touch on some of that tonight. We might not, but I'm going to now come back to James. James, more and more people are getting dry, tired, watery eyes, and it seems to be getting more common. Why do you think that is, or why do we know that is?
Very good question. And the answer is we know relatively little because people haven't really looked systematically at dry eye until more recently. But obviously our lifestyle has changed. And one group that we are now looking at is children who typically we've always presumed have a great tear film. You have a really good tear film as a baby and you should carry that forward. But the reality is when we actually look at children, we find 1 in 5 actually have a fully diagnosed or diagnosable dry eye. And that seems to be associated to damage to their glands, the glands that produce the tear film, particularly the oily layer that protects the tear film. And that is very correlated with the amount of time they spend on screens. So obviously our lifestyle has changed enormously, particularly with digital devices. But even just, the fact that we live in very air-conditioned environments now, all of those things will affect your tear film. The tear film is 1/10 of the thickness of a human hair. And so pretty much anything can disrupt it if you change the environment around the ocular surface.
We had some good tips, simple tips from Diane last night around simple things people can do. But probably one of the things we haven't covered quite so much in these webinars, what exactly is dry eye?
Very good question. So dry
If
eye
only it was
is
that simple.
yeah. So we define it as a loss in the homeostasis, so the balance of the ocular surface and tear film. So our eyes have been designed with a transparent window, what we call the cornea, on the front of the eye. But to be transparent, it can't have any blood vessels, which is why you can see the blood vessels going over the white of your eye and then they stop at the transparent part. Because obviously if the blood vessels went in, then you wouldn't see through them, and also that the tissue would no longer be clear. So we need a solution to things like nutrition. How do you get nutrition to those cells on the front of the eye? That comes from your tear film. You also need to keep a very careful balance of hydration to keep those cells clear. And again, that comes from our tear film. And also being exposed to the outside world, it needs protection such as your sort of antimicrobial agents that are also in your tear film. So essentially the tear film is there to provide all of that and a smooth optical surface. If we just had the cornea and no tear film, actually your vision wouldn't be very good. So this very carefully balanced solution and the production of that, the distribution of that over the surface, and then how it leaves our eye down into your nose is that careful balance. And things that disrupt that balance, and that could be, environmental factors, it could be systemic disease, it could be the medications that you're on, cause this disruption. Now, we call it dry eye because the majority of people, their symptoms are about dryness. But actually, there are other people who their symptoms are wetness. And we still call it dry eye. But essentially, because the surface has become damaged and simulated, that can actually cause what we call reflex tearing. So the sort of tearing you get when you cry, where the system is trying to restore that water, but because it's just from one of the glands and not balanced, it doesn't actually provide that relief that ideally we would like.
Yes, so that is the sort of curiosity, isn't it, that people don't understand when they walk in complaining to their practitioner of watery eyes that they're then told, oh, that's because your eyes are dry.
Yeah.
You have a video, I think, that shows the sort of system of how the tear flows. It might be a good idea to share that right now.
Yes, very happy to do that. Let's see whether this works. Okay, so you can see it here. Hopefully we can get that video going. There we go. So essentially every time you blink, you're squeezing the glands that are in your eyelids themselves. They produce that oily layer. We call them the meibomium glands. So the meibum, the oily surface, is there to reduce evaporation, but it also gives us an even spread of the tears. But the bulk of the tear film actually comes from the gland up here in the top right. That's your lacrimal gland. That's when you cry, for example, that's the gland that's being stimulated. And that's the main watery substance. And that is what contains a lot of the nutrition, the antibacterial agents, for example, that are part of your tears. And as you can hopefully see in the video, it's all part of a complex system. So every time we blink, squeezing those glands, getting the oil onto the surface, picking up that tear film, spreading it over the ocular surface, and slowly that migrates to a little hole in the corner. They call that the punctum. You can have little plugs to stop that draining away. And then actually that goes down these little canals, and your nose is in the far left-hand corner. So that's where you get rid of those tears once they've been useful to you.
That is, I mean, that is a very good way. I think it's the first time we've diagrammatically shown that. That is very good. And as you say, you can see a lot of people are probably familiar with meibomium gland dysfunction. They may have been told about that, might have heard about it, or MGD for short. Do you just want to, as the glands are visible, just touch on that for us?
Sure. So you can see these sort of long, thin glands within the eyelids. I just got. So those are your meibomium glands, and they produce these oils, a little bit like your lung. They have these little sort of alveoli type systems where they produce those oils, and then you've got little holes just at the lid margins, and it's from that the oils are expressed. So as you can imagine, because you're pumping them all day long, they stay healthy, they stay active. If you stop that pumping action, and we know when you stare at a screen, actually you blink a lot less. And what we do is we tend to partially blink, so the blink doesn't fully close. So because we're not then using those glands, the oils in them essentially can clog up. So the area, the punctum, so the actual orifice, so the hole onto the ocular surface can block. So the gland now is producing oil, but it can't go anywhere. And what happens is that gland then essentially dies off, so it becomes shorter. So one of the things that we do is we can actually invert the lid, turn it over, and have a look at those glands. And in people who have spent a lot of time on screens, for example, or have dry eye, quite often we see those glands have got shorter. And we know from our studies that if the gland is shorter, then it tends not to produce a nice clear oil. It tends to be a more murky oil, or even like a toothpaste. And it's less likely that those oils are managing to get onto the ocular surface. And that's why we have treatments. Warm compress is one that's probably fairly familiar to the people on this call, where essentially we're raising the temperature, making it more liquid, and then we massage the lids to try and help those oils flow naturally onto the ocular surface. And we can also do a treatment called expression. So it's not the most comfortable procedure, but we can essentially squeeze on those glands, getting the oils to come out onto the ocular surface, hopefully breaking that blockage, which is stopping them getting onto it.
Yes, our colleagues find expressing glands particularly satisfying because one can liken it to squeezing a whitehead and the satisfaction that we sometimes get from doing that.
Yeah.
We also we talk about dry eye being chronic and progressive. And probably come off the video now. The Can you just sort of talk us through that a bit?
So that again, so in terms of it being progressive and chronic?
And chronic, yes.
Yes. So as you can imagine, if the tear film is unstable, it will cause problems on the ocular surface in terms of inflammation. This is our way that the body deals with irritation to the eye. And that inflammation then does damage to the ocular surface. And because the ocular surface is now damaged, the tear film will be more unstable. So they call it the vicious cycle of the disease. So actually, once you're in that cycle, it's quite difficult to get out. And that's why it's a chronic condition. This is not something you can just treat and it goes away. We don't have very good evidence in terms of how it progresses with time. So it's not that, well, I've got this disease now and it's going to get a lot worse. And it's more about trying to make it manageable for that individual. And there will be circumstances, maybe in terms of work or where you are, humidity, those sorts of things that make it worse. There'll be other things that perhaps make it more manageable. And for many patients, they're able to describe to you a particular time of year, for example, or a particular activity where they know they're going to struggle more. And we can try and then target treatments to help in that particular circumstance.
Yeah, because I mean, different people will have different triggers, won't they?
Yeah.
That sets things off. And we use the word treatment, and treatment often suggests that there's a cure. That if you use the treatment, you'll be cured. I think increasingly professionals, we describe it as management rather than treatment.
Yes, I would agree. Very rarely do you hear of people who no longer seem to have their dry eye afterwards. And it might be that it wasn't dry eye at all. It was just mimicking the symptoms, because there are plenty of things that do mimic the symptoms. But you're right, in the majority of cases, it is about that management, both from the professionals, but also self-management to get that symptomology down to a level that's manageable.
Yeah, exactly. I mean, it's actually a good point to just touch on, because there are other things that mimic dry eye or give dry symptoms.
Yes.
Could you give us a couple of examples? Because it's important that just because you have dry, gritty eyes, it might not be dry eye, might it?
Absolutely. So the main examples are allergy, ocular allergy. Interestingly, the eye is uniquely sensitized. So some people will have allergies in general, hay fever, and have their eyes affected. Some people will have hay fever and not have their eyes affected. And there's some people who have allergy in the eyes, but not in the general body. So this is one that, again, will give you a gritty eye, very uncomfortable, but actually the management of it is different. So here we're trying to dampen down the particular features of inflammation and allergy rather than managing dry eye. Now, having an artificial tear will certainly help even if you have allergy, but it's not the primary treatment for you. So it's important to differentiate that. The other one that's very common is an infection. So if you have some kind of infection, particularly if it's a low grade infection, so maybe the eye isn't incredibly painful, but it's uncomfortable, it's irritated, it might be watering, it might feel dry. Now, in those cases, it's often in one eye rather than both, and dry eye tends to be more in both eyes, not necessarily evenly between the two eyes. But it's really important that in those cases, if it seems to be more one eye, that we actually have you in for an examination, because again, the treatment that we will have, and that is a treatment, is different in that case.
At what point do you think people with sort of some kind of irritation, is there an obvious time and probably that, or an obvious thing that would make that you say, right, you ought to go and see someone about this?
So certainly, if there are any of the red flags, and I can, I'll just put up a slide which will give you some of those red flags.
While you're doing that, James, I'll just let everyone know there. Thank you. Someone's already put a question in, but you'll see at the bottom of your screens. In fact, two people have put questions in. Please feel free. We'll deal with the questions in a sort of 5-10 minute session at the end. So please feel free to pop in any questions as they occur to you.
So these are my sort of red flag questions. So certainly if the eye is painful rather than what I would call discomfort, that would indicate that there's more going on, and that really ought to be examined. If you have dryness of other surfaces in the body, particularly the mouth or enlarged glands, now that might be dry eye still, but there's a condition called Sjogren's disease that causes dry eye, but also some other problems in the body. So again, that's important that we examine for that. If there's a particular triggering event, so typically if someone's got a twig in the eye, for example, and then actually you've got those dryness,
James, can you hear me? You've broken up.
that
The
be
challenge
some
of the challenge of webinars when the broadband starts to break up a little bit. James, can you hear me? Apparently not. The good job, the useful thing at this point, until James comes back, is that you can see on his slides and that what we're talking about for differential diagnosis and things to look out for.
Just not healing properly. That's something fine. Are you hearing me okay? Otherwise,
I've just started to hear you
Nick.
better. We lost you for a good.
Nick,
Can you hear me?
I can hear you absolutely fine. I've turned my camera off, so hopefully that remains.
Yeah, we
Good.
see, yeah, we missed most of that, but I think everyone will have read your slides, and I did touch on some of the points once you'd gone.
Fantastic. Yeah, so these are things just if any of these feature alongside that grittiness.
We can't see your slides. Sorry, James, it's gone to your windows.
Oh, that's a bit strange.
Not your slides.
Let me just stop the sharing. Are you managing it now, Nick?
Do you want me to try? Because I have your slides. Oh, I think I might. Did I close them off? Hang on a second. No, I still have them. Let me bring your. I might be able to bring your slides up myself. That's probably the easiest thing to do.
Yeah.
There we go. Share. Right, we're back.
Can you hear me?
I can hear you, and your differential diagnosis slide is now on the screen. Tell me if you want another one.
No, that's absolutely fine for now. So yes, these are the main triggers where you would be thinking about getting a full eye examination at that time. If these are not things that go along with your symptoms, it's probably reasonably okay to try an artificial tear or a warm compress, lid wipes if there's sort of dandruff along the eyelid margin. But we know that you should get benefit within a month. So if you don't get that benefit, it would well be worth, again, going and seeing an eye care practitioner that specializes in dry eye.
We touched on it with Dermot with regards to the best people to go to. Um, and in my view, do you share the view optometry? And I think a lot of people don't realize, the expanded role that optometrists generally have these days, and that increasingly with the pressure on ophthalmology in the hospitals, optometry is a very good first port of call for patients with all sorts of eye problems, but including dry eye.
Yeah, I would tend to agree with that. Hospitals have very long waiting lists. In fact, ophthalmology has the longest waiting list pretty much across the whole country of any hospital discipline. So optometrists are well versed and well placed. I would encourage you to see someone who is specialized in dry eye. And one way that you can find those people is through our app. So Nick, you might want to show I think it's the
Yes,
last slide.
I will bring that up actually. Just the other thing you might want to touch on is, which is coming up first before that, is of course you and others have founded a dry eye association.
Sure. So this came out of that there wasn't really no way for patients with dry eye to talk to other patients with dry eye in the UK. There was the Dry Eye Foundation, which is very good in the States, and some of UK people joined that. But actually, it's really nice to talk to people who have the same access to treatments, etc., and you can share examples. There's some really nice articles on this website about what to do when you're doing long haul flying, for example. How do you juggle your treatments so they're available at the right time for you? So we set up this organization. It's a patient organization run by patients for patients. And we have many members now in the UK. You can see we also have a New Zealand branch as well. But by being a member, you'll get access to their newsletter. There's plenty of resources that you can access for free on the site. And we tend to run a yearly education day, which is free of charge, where you can come and meet other people who have dry eye and discuss what we should be doing to make your life better. So that's the Dry Eye Association. And part of that is that we have an app. Now, obviously, you may not want to be staring at screens all the time, but hopefully this is useful to you. It's available both on the App Store and Google, so should be available on pretty much any smartphone. And what it allows you to do is to go through your symptoms and your environment, so you can pick out those things which are known risk factors for dry eye. You can do the valid questionnaires. So again, you can map your own symptoms over time, which is really helpful when we are thinking about what's optimum for you. You can put the treatments that you're on. So let's say you're on an artificial tear and you've been told to take it 4 times a day. You can set reminders for those 4 times a day at times to suit you. And again, these phones are very good. They'll send you notifications as you want to remind you that maybe you haven't taken it in the morning. I certainly forget whether I've taken things at a particular time of day. And it actually allows you, and we're working on this, to actually monitor when you take those treatments. So again, it helps you to say, oh, yeah, no, I am managing to do it at least 3 times a day, or no, actually, this just doesn't fit with my lifestyle. I need to use something different. And then finally on it, it has a map search. So you can put in your postcode, you can put in a particular treatment that you want, like intense pulse light therapy, and it will tell you the closest practitioner or the practitioners around you that have that particular treatment available. So hopefully this is useful for you to manage your own dry eye, but also to give you those extra resources as well.
Yeah, I have to say the app is a brilliant resource. And talking of one of the things I did want to mention, the dryeyezone.co.uk has a map on it on the Dry Eye January page that also will enable you to find practitioners who are participating in this Dry Eye Awareness Month campaign. So they're all specialists in dry eye. So again, you can go on that and there's a map on the Dry Eye January page where you can find practitioners that can potentially help you. Um, the other thing about, similar to the Dry Eye Association, the Dry Eye Zone has a lot of blogs. Over the last few years, we've created a lot of educational content that is generic. It really does just talk about dry generically and looking at various aspects of it and various bits of advice. So if you want more information on dry eye, as well as the Dry Eye Association, please visit dryeyezone.co.uk. Now, I think, James, what we'll do is we've got 7 questions in so far. So let's get going on those as we're getting up near to time. Um,
Great.
this is anonymous, but I had crystals growing on my eyelids, which have been removed. I purchased a heat wand, which has helped, but they come back if I don't keep them lubricated. Will a heated face mask help too?
Okay, when you're referring to crystals, I'm
Mm.
presuming that's something to do with the marbum, so what should be coming out of the glands. Perhaps those oils are solidifying on the lid margins. So certainly, if warm wand, for example, helps with that, then an eye mask certainly should. So they work by a sort of similar principle. Um, Now, many of these devices have not been tested scientifically, and the bar for marketing a light therapy is quite low. So, unfortunately, it's very difficult to sort of recommend a particular product or even the sort of technique. But in principle, yes, a sort of heat mask should help and should allow those oils to flow if that's what's causing the problem.
Thanks, James. Bridget asks, how do I manage dry and hay fever? Which drops to go in when?
Very good. So, with hay fever, particularly with an ocular component, there are two sort of main pharmaceuticals that are used. One is an antihistamine, which is one of the chemicals that's released when you have that allergic reaction. And the other one is a mast cell stabilizer. And that's what actually has those inflammatory components in it, and it bursts in allergy and releases those components. So in theory, a mast cell stabilizer should be used before you start having the symptoms. So I know every March I start getting my allergies. So in February, I want to start on my mast cell stabilizer to mean I don't get to that stage. The antihistamine should have a more immediate effect, but less effect than a mast cell stabilizer. Both of those are available over the counter. The mast cell stabilizer is called sodium chromoglycate. But actually, we know the most effective treatments are the combination, and those you can only get prescribed. So, a combination of an antihistamine and your mast cell stabilizer. That said, there are non pharmaceutical things you can do. So, we know that eye drops dilute the antigens, the particles that get into the eye. So, those are helpful. And a cold compress will dampen down your inflammation as well. And just simple things like washing your pillow regularly, because of course that picks up those dust mites or pollen, and so sleeping for long periods of time, lying on that pillow can have an effect. So you'll notice there that some of those overlap with dry eye treatments, like the artificial tears. They will help with allergy, but they will also help with dry eye as well. And there's quite a lot of overlap between allergy and dry eye. So it's sometimes difficult to tease out for an individual patient what's causing that problem at this time. So actually that combined therapy is really quite useful.
Well, of course, one of the things, if you take oral antihistamines, is they tend to have a drying effect on the eyes.
They do, yes. So again, it's a little bit difficult. Many medications you'll find have those effects on the eyes. And I just would encourage people not to stop using something without the advice of that prescribing doctor. So again, just getting your professionals to talk to one another, because obviously you don't want to stop your heart medication, even though that's causing more dry eyes. Sometimes we have to live
Absolutely.
with that. Other times there are things that they can change to a treatment that's just as effective but has less effect on your eyes.
Um, have you found scleral lenses useful in dry eye symptoms?
We have. Um, Now, this is an interesting area where there's relatively little research. There's beginning to be more research. But for those people who don't know, a scleral lens is a big, rigid lens that vaults over the clear part of the eye, lands on the white part of the eye, and actually contains liquid. So you put liquid in it and then onto your eye. And because you're bathing your eye in that liquid all day long, and because you're protecting your eye from the action of the eyelids, they have been found to be very comfortable by people with dry eye. Now, that said, a lot of dry eye patients struggle to wear contact lenses. So it's not the perfect solution for everyone with dry eye, but certainly for more sort of moderate to severe dry eye, they can be an absolute lifesaver. Um, so they are well worth trying. They're quite difficult to get right. So again, you need a specialist practitioner to do that. Those generally are optometrists, although there are some hospitals that will do it. But generally, you'll probably find it easier to get it fitted in community optometry. And then if that works for you, try and get an appointment in the NHS to maintain that.
Great, thanks, James. The questions are coming in thick and fast. Surgery mentions retinal detachment and cataract here, but of course, laser eye surgery we know can result in dry eyes. Do you want to just touch on why?
Yeah, so with any in your the transparent part of the eye, the cornea, you have nerves. It's actually the only place we can see the nerves without cutting into your body. And actually, you have more nerves per square millimeter than anywhere else in your body. So that's why our eyes are so sensitive when we get something in them or an eyelash. So any surgery is likely to cut into those nerves. Now, we're very fortunate. Things like cataract surgery have developed. So now it's absolute microsurgery. So it has relatively little impact. But if the ocular surface is not perfect before you do the surgery, it can cause problems afterwards. So even in people with no symptoms at the moment, if they have surgery done, it might cause long-term symptoms. But particularly laser refractive surgery, because it's a larger area that we're interacting with the cornea, can cause very significant symptoms, particularly in those people that don't have a perfect ocular surface beforehand. So it's really important that that's checked before you go for surgery. There are people who really shouldn't have surgery because their ocular surface we can't make perfect beforehand. But for those people who are going to go undergo surgery, again, there are management strategies we can put into place beforehand to try and get the ocular surface as good as possible before that surgery. And actually, it's getting much better, the awareness of that, and people looking much more closely at the ocular surface before they do those surgeries. It is an area of active interest, and there are more papers now coming out on different treatments that we can do before surgery to stop the problems afterwards. The other thing with cataract surgery, we need to measure the shape of the transparent part of the eye to choose the optimum lens for you. Now, if you've got dry eye, actually that can disrupt the measurements that they take. So again, that preparing the ocular surface beforehand can mean that we get better measurements, which means that we can get a more perfect solution for you in terms of your vision after the surgery.
A very comprehensive answer. Thank you. There are a lot of questions. I'm going to skip some of, I'm going to try and sort of hit on the ones that might be of most common interest. And apologies to those of you who've got a bit more specific about your own personal medical conditions. Is the meniscus test the best test for aqueous deficient dry eye?
So, in terms of dry eye, we used to think of it as evaporative and aqueous deficient. So, more to do with those lacrimal glands up here that produce the sort of tears when you cry. That's your aqueous, main volume of your tears. And yes, measuring the height of the tear meniscus, the vast majority of your tears reside in that meniscus. So, if you've got a low volume of tears, that meniscus reduces. And because we can image that without putting any drops and things in your eyes, it gives us a very accurate measure of basically how much volume you have, which is largely down to that aqueous.
Right. The Julie asked, can you just briefly explain correlation between autoimmune conditions such as vitamin B12 deficiency and dry eye?
So there are lots of risk factors for dry eye, and vitamin B deficiency is one of those. So anything that disrupts the natural tear film and the balance of your ocular surface then can lead to dry eye. And certainly in terms of those sort of more inflammatory type, rheumatological type conditions, they are very strongly associated with dry eye symptoms.
Very quick one. Will gland probing? I don't know if this is someone has is one of us or has heard about gland probing. So probing the meibomian glands. Where do you? The question is, will it help? I
Yeah.
guess the question to you is, where do you stand on gland probing? Because it's a bit controversial.
It is controversial, and I am someone who is quite nervous about it. As I've already explained, this is quite a complex structure, your meibomian glands, and to stick a metal probe into a small hole to try and make the tears come out more easily, the meibum come out more easily, the danger is that you do some damage in the process. And certainly my understanding is that it quite often bleeds, and bleeding causes what we call fibrosis, so an unnatural formation of cells to block that bleeding. So actually that's more likely to block the gland. You might get some immediate relief, but block the gland in the long term. So it's not something I would recommend until we have much better imaging techniques so we can see exactly what's happening if we put a probe into the eye. It's much better to try and remove those blockages with heat and allow the glands to flow more naturally.
I've got a couple. We'll probably wrap it up shortly. I'm sure we could go on, and those that are interested would happily stay, but we do need to not go on too long. There's two questions here that or comments and questions that I think we could probably tackle a bit together. One, the Deborah says she can't open her eyes in the morning due to MGD. She tried steroid drops, Blefex, punctal plugs, none have helped. Is it worth trying doxycycline? She does make the point her MGD might be low estrogen related. And then there's another question around, is taping the eyelids down while sleeping help? And if you don't shut your eye completely. And so problems in the morning, really.
Okay, so there are a few things to think about that. It might be, as it's been said, that the eyelid is not closing totally. There's a test that can be done, basically putting a torchlight against your lid and seeing whether any of that gets out through the lid margin. So that's something that your eye care practitioner could do to try and sort of give some more information. I do know patients that do tape their eyes shut and they get some relief from that. Probably more conventionally, we would recommend using a gel at night. So normally an artificial tear is reasonably liquid because we want it to flush with the tears. The gels can affect your vision. So we wouldn't generally use those during the day, but putting it in last thing at night can hopefully protect the ocular surface. We tend, because we're not blinking, to produce tears overnight. So that protection then stays in place and then will be washed out in the morning. The other thing to watch is again, if you've ever had, let's say, a twig in your eye or a baby's fingernail, sometimes that can cause a disruption to the ocular surface that is worse again first thing in the morning because the dryness essentially rips the cells off when you first open your eyelids. There are managements and even treatments for that. So again, this is another good reason to go and see your eye care professional. They'll put a dye in your eye and they can see whether there is this kind of damage. And there are treatments and strategies to try and improve that. So those are probably the first things that I would say. But again, with all of this, it's really important because I can't determine exactly what's happening with your eyes without looking at them, to go and see an eye care specialist who can give you that more tailored advice.
I think we'll make this the final question, James, because I think it's again a good question. Do you find HRT is helpful for drying women that are possibly premenopausal or menopausal?
Again, a very good question. Some people it really helps a lot, and in other people it really doesn't. And it's really quite complex, the hormones and how they change in your body over time. So we certainly know hormonal imbalance can affect the tear film and cause a very dry eye. Again, typically more the aqueous type. So having someone examine that for you, they can tell you whether that's probably the main problem and therefore perhaps more hormonally based. But it is a try and see. Yes, there's the science isn't all one direction in terms of HRT helping, but certainly it does seem to help others, perhaps make it even slightly worse in other people.
Oh, you hit on a good phrase there, really, which probably sums up dry eye management strategies. There's a lot of try it and see, isn't there? Because, it is very patient dependent, and it also is down to accurate diagnosis, which you might not have got to.
Yes, absolutely. And what's changed over the last year or so is we have a far better understanding of the sort of main drivers of dry eye and how to work those out in an individual. So this will allow us to tailor management more for you. But as you say, particularly when it comes to things like artificial tears, they're very complex. And companies, thankfully, have put a lot of time and attention in terms of the components in those. But there are lots of people who find some of those components irritating. And likewise, with particular compounds like hyaluronic acid, not only does it depend on the concentration, it depends on the molecular weight, lots of things about complex chemistry. So you can't just say, all right, well, this works and therefore everybody,
Yeah.
this is the solution. It is about, we can target initial treatments, but if that doesn't work for you, we have plenty of more in our armory to try and get something that is going to manage your symptoms.
And thank you, James. I think that kind of brings us to a good conclusion. This is the longest we've run at 45 minutes. So I think a very comprehensive review of what dry eye is and potentially how to manage it. And so I thank you very much. I'm sure everyone's enjoyed it. Don't forget you can visit the Dry Eye Association website or the Dry Eye Zone website for more information generically about dry eye. And don't forget, we have a webinar next week, which will look at other aspects, some of the modern talking, James, about some of the treatments and the wand came up,
Yeah,
and looking at these devices next time with optometrist Nicola Alexander. So thank you, James,
my
and
absolute pleasure.
thank you everyone for tuning in. Bye now.
Take care.